Vice President Forum for Enhancement of Quality in Healthcare, FEQH, member of board, IPAS Development Foundation, ex-chair Publication Committee, AOFOG, ex-chair Reproductive Endocrinology and Infertility Committee, ex-chairman MTP Committee, FOXY, 2004 and 9, consultant Ashwini Maternity and Surgical Hospital, Center of Endoscopy and IVF, program director and member of board, ProFert IVF, consultant Jupiter Hospital, Fertility and IVF Clinic, visiting consultant for IVF, Aloka Jabalpur, Jalandhar, Vasai, and Yavatmal. Now, Dr. Tang, please guide us and tell us the latest recommendation for vaccination in pregnancy.
Thank you very much, madam, for that very kind and generous introduction. Let me first begin by thanking my dear friend and guide, Dr. Laxmi Shrikhande, who's also the convener of this quite wonderful conference, and ISOPAB, both the national and the Vidarbha chapter, for inviting me for this presentation. It's a pleasure to see the president of the National ISOPAB, Dr. Usha Sharma, the Secretary General, Dr. Meena Samant, and the Treasurer, Pragya. And of course, from the Vidarbha ISOPAB, there's Milind, Sneha, Dr. Lakshmi Madam, and Dr. Alka Mukherjee. I'm going to speak on vaccines in pregnancy, and I understand that I had around 15 to 17 minutes to speak, so I will try and make sure that I complete the presentation in that much time. We'll talk a little bit first about contextualizing vaccines as in general. We'll then talk about the vaccines which we were using and are now using in managing vaccinations in pregnancy. And then, of course, we will wind up with what is literally a $1 million question, and that is the COVID-19 vaccine and pregnancy. So that will be the sequence of events in which the presentation will unfold. Vaccines, as you all know, has a very rich, interesting kind of a history. It is said that the ancient Indians and the Chinese were already doing some form of vaccination many centuries ago, before Edward Jenner started formally vaccinating for the smallpox vaccine. And then, of course, you had the Salk vaccine, the Sabin vaccine, Louis Pasteur with the rabies and anthrax vaccine, and then Calmette and Guerin, who started talking about the BCG vaccine. But I would have to say that the peak of triumph for vaccination, although we hope is still to come, did take place in 1979, when the World Health Assembly officially declared smallpox eradicated. As they said, a feat that remains one of history's greatest public triumphs. And we have currently several diseases that are actually preventable by vaccination. Traditionally, vaccination has been thought to be the arena or area or territory, if you will, of pediatricians or general physicians. But obstetricians and gynecologists are also very important players in vaccination, because vaccination in pregnancy is an opportunity to protect women by building up active immunity and also affect the neonates and infants by transfer of passive immunity. Pregnant women as a whole seem to be a receptive population, particularly when they are already there in the health systems. And of course, because we stay with the patients for a very long time, acceptance is very high when we as obstetricians and gynecologists recommend vaccines. Tetanus used to be the sort of a forebearer of all vaccines in pregnancies, and 2 doses of tetanus toxoid were the standard recommendation from the second trimester, 28 days apart. At that point in time, it was thought that natural disasters and war increased the risk of tetanus, and even if tetanus was relatively rare, When it does occur, it is lethal. On top of it, the vaccine for tetanus is safe, effective, and economical, which causes huge reductions in tetanus related mortality. So, this used to be the national immunization schedule once upon a time for pregnant women when tetanus toxoid injections used to be the recommendation. Of course, now, as I already said, we have several more vaccines, and sometimes it is easy to get confused in this alphabet soup of big T, small t, big D, capital D, and all. So, just as a sort of a clarification, the bacterial diseases are grouped together, that's tetanus, diphtheria, and pertussis, and this terminology is based on the component, the quantity, and that's where the capital or the small letter goes, and whether it is whole or acellular, for pertussis particularly by an addition of W or A. So that's why for children you have DTWP, where the W means it's whole, DTAP when it is acellular, and similarly for adults you have TD and then you have Tdap. It's a misconception that diphtheria is a disease of infants and children only. Since the last 2 decades, India has actually seen four major outbreaks with an annual mortality of 3,300. And in fact, 79% of these cases were reported in the more than 10 years age group. And therefore, it stands to reason that a booster for diphtheria is needed for adults. And over a period of time, as we have got very efficacious TD vaccines, it has resulted in the end of the tetanus toxoid era. So the national immunization schedule I showed you earlier has now been replaced. And in the universal immunization program, this is what you will see on the government website, that the tetanus toxoid vaccine has been replaced with a TD vaccine to limit the waning immunity against diphtheria in older age groups. Pertussis vaccination also is given in pregnancy, and the main reason that it is given is that infant immunization is not protective for pertussis until 4 months of life. Infants at this time can get infected and have serious morbidity and mortality. In fact, more than 75% of pertussis deaths occur at less than 3 months, and about 25% of infants who get infected either get a pneumonia or an encephalopathy. All this can be prevented by passive immunity from the mother. A very important reason why a mother should also receive pertussis vaccine. And therefore, you had all the global recommendations. So you had the TD, and now you have all the global recommendations on Tdap. And Foxy also has recommendations on this, which say that Tdap should be administered in pregnancy in order to provide optimal protection to the baby during its first few months of life. There is also the administration of influenza vaccine in pregnancy, but remember you have to give the inactivated vaccine. It's recommended as a single dose. It may be administered in epidemics, influenza, and the present coronavirus. But remember that this vaccine
आप
changes
दिव्यांशु
every
आज हम
year
अपने से करिए
depending on the viral strain.
हम सब काम हो रहा है
The reason why this vaccine is important is that pregnant women are more susceptible to influenza. The likelihood of ARDS due to flu is higher in pregnancy. And of course, this vaccine also confers to protection to the newborn who are not to be given this vaccine till the first 6 months of life. So if you look at that chart in purple over there, those are all the standard vaccinations in pregnancy and discussion on them. And on the right over here, you will see a small little chart, which is quite easy to remember. 12 to 16 weeks TD, 20 to 24 weeks influenza, and 28 to 32 weeks Tdap. 0.5 ml IM given in the upper arm. So these are the current vaccines that should ideally be utilized in any pregnancy for our women. What should be the duration between the two vaccines? At least 4 weeks. Does the time of the year or the season affect? Yes, of course. I mean, if you are nearing the flu season, you should try to give the influenza vaccine a little earlier. If the patient comes late for registration, can TD or Tdap be given with the flu vaccine? The answer is yes. If time is short and you need to give the immunity, you can administer it. The principle essentially is that do not administer live attenuated vaccines together. MMR, varicella, and BCG vaccines are quite clearly contraindicated in pregnancy. However, if a woman is unknowingly immunized or becomes pregnant within 3 months of immunization, you need to tell her very carefully about the remote theoretical risks. Remember, although it's not an automatic indication for MTP, a lot of patients will opt for MTP as a matter of choice. If you are going to give the MMR vaccine or any of these vaccines uh, to a patient who's planning a pregnancy, please remember to write it on paper that the patient has been counseled about the adverse effects if she gets pregnant after the vaccination, and she should try and avoid pregnancy for at least 2 or even 3 months after this vaccination is taken. Sometimes patients need to take yellow fever vaccines because they are either going abroad for work, particularly to Africa, or are joining their husbands for work. So can you give yellow fever vaccine in pregnancy? It's a live vaccine and has a theoretical transmission risk. So as far as possible, you should try and avoid giving this vaccine in pregnancy. If a patient has an animal bite, you can give rabies vaccine in pregnancy. Remember, it's life-saving, and in that situation, you can even use immunoglobulin. Although we talk about the need for improving the number and the type of vaccines that we give in pregnancy, let's also remember that they are associated with an economic burden. However, if you look at it in a cost to effectiveness or a risk to benefit ratio, it's quite obvious that giving the vaccine is much more beneficial compared to not giving the vaccine. There is also a hesitancy to change practice when we have been using tetanus toxoid as the standard vaccine for so many years in our practice. It sometimes is a little difficult to adjust our minds to using TD, Tdap, and influenza vaccines in pregnancy. Even when we changed our practice, it did take a little while to start advising or for that advice to become automatic, but I can assure you that it is a change which is worth making. Of course, fake news or links about vaccine related serious side effects are always something of concern which need to be looked into. There really is no correlation between MMR and autism or even HPV and deaths. In fact, such fake news is quite detrimental to public health as a whole, and as uh, advocates and as health providers for women, it's our responsibility to debunk these myths with our women whenever possible. If someone comes to you for preconception advice and asks you what vaccine should I take, then these are the vaccines which you need to advise the patient about, MMR or MR or varicella. Remember that what I told you, write it on paper that this vaccine has been given and the patient is advised to avoid pregnancy for some time. You could also give hepatitis B or HPV, but for these, there is no need to delay the pregnancy. If there is a patient who's unfortunately not been vaccinated with these vaccines earlier, then it's a good idea for the patient to catch up with the universal immunization protocol once she has delivered. So let me conclude this talk, or let me bring us to the last portion of the talk, and that is the COVID-19 vaccine and whether we should be using the COVID-19 vaccine, which is shortly, I believe, next week going to be available for our pregnant women. It is, as you can see in the graphic here, the pot of gold at the end of the COVID rainbow. But let me first put or try to put things in a little of a perspective. And the fact of the matter is that purely statistical views create panics. I remember when the COVID-19 pandemic was just taking off and we were starting to become more aware, and this person came on television and so many channels and so much coverage of him where he said that a couple of million, 20 lakh Indians are going to die by July, and this was in March. Obviously this was extremely sensational, and it really scared the wits out of everybody. Fortunately, as you can see, the number was nowhere close to what was projected. And I think sometimes when we talk about forecasting, it's easy to forget that forecasts, generally speaking, have a strong tendency to overpredict. And therefore, it's very important that when forecasts are made, you have to communicate the uncertainty which surrounds the forecast very well. So for example, this article by Dibyendu Mondal, who said that India is actually one different country every couple of 100 kilometers apart. And there is no way that one mathematical model of prediction or forecasting can actually work for the entire country. And that's why even at that time, there were people, including me, who were saying that the forecasts were going to be found absolutely wanting, and the morbidity and mortality was going to be much lower. Well, fortunately, that's turned out to be the truth. This is data access just yesterday. And if you will see the deaths per 100,000 population in both the graphs, you will see that inexplicably, I mean, I don't think we really have any good explanation for this as yet, but the deaths per 100,000 population in our country are remarkably low, much, much lower. I mean, it seems in a strange kind of a way that the better the health system of the country is, the worse is the outcome as far as the coronavirus goes. And that's what you could infer if you actually look at the countries on this graph. Having said that, of course, one has to be thankful that the corona pandemic has not affected the world anywhere close to what the last influenza pandemic affected us, which was infecting a third of the world's population with a mortality of 50 billion people. So whenever we are talking about the coronavirus, I think it is crucial to understand that you're talking about a very compressed time frame. You're talking about looking at evidence which has been generated in a few months versus what we are used to, and that is a few years. And that is why you really need to mix pessimism and pragmatism very well before you decide or not whether you are going to use the coronavirus vaccine. So these are all the new technologies, and these technologies actually have been developed for the HIV virus. And look at the standards that were used in the past when they were giving vaccination. Albert Sabin, when he delivered vaccine, he gave it to 100 adult volunteers, and he was so happy with the outcome. He said, now I'm going to go and give it to my wife, 2 children, neighbors, and their children also. So normally, when you're looking at the development of a vaccine, you're looking at a cycle of close to 14 years. So if you look here, that's the phase 1 trial, which is supposed to determine the dosage, the phase 2, which is supposed to determine immunogenicity, route of delivery, dosage, and the schedule, and the phase 3 is only supposed to look at safety efficacy in a large population group. Each of these phases is supposed to last for years together. And for the coronavirus vaccine, we have compressed this 14-month period into less than 8 or 9 months. So obviously, the evidence that you are going to ask for as far as the coronavirus vaccine is concerned is limited, and therefore should not be held up to the same stringency, because this is not a situation like any other where you can simply wait and wait till the things sort of blow over. So what is the current status of the two vaccines which have been approved in India? One vaccine is a viral vector vaccine, and the other is an inactivated whole SARS-CoV-2 COVID-2 virion, which is an old platform. Now remember, Pfizer and Moderna are vaccines on a very, very new technology, which is the mRNA vaccines. These vaccines are based on technologies which have been found to be safe and efficacious over decades. These are not very, very new vaccines as far as the way the vaccines work is concerned. Both have undergone a good amount of trial, and both the subject expert committee and DCGI have said that both these vaccines are safe and produce good immunogenicity. So what is the current rule? The current rule is that both vaccines are going to be made available next week. The Bharat Biotech vaccine is going to be available restricted use in clinical trial mode, which doesn't mean it can't be used. It means that you have to recruit patients for the vaccine properly and follow up those patients properly. So both these vaccines are going to be available next week. The question is that will these vaccination drive succeed? Because the journey of a vaccine only starts when you start manufacturing the vaccine. The vaccine has then a very complex journey till it reaches the last mile. Fortunately, India is a global champion in vaccination. India manufactures 60% of vaccines globally, and we plan to immunize 300 million people by July 2021. This is not less. It's not less, because even immunizing maybe a certain percentage of population is going to break the chain of infection and reduce morbidity from coronavirus very, very significantly. This attempt is going to prioritize healthcare worker, emergency services, and remember, you have to be optimistic about this program, because India's existing vaccination program already reaches about 55 million people a year. I mean, this has really taken a step up with the Indradhanush immunization program. So India has shown itself to be extremely proficient in vaccination. The system stocks and tracks the vaccine through a well-oiled electronic system. I, for one, am very optimistic about the rollout. The question relevant for us, should we give it to our pregnant women? The answer is we don't know. Like so many other things with the coronavirus, there is a completely sort of a divided opinion. What is true is that there is no evidence, one way or another, for the coronavirus vaccine in pregnancy. The American College says, leave it up to the pregnant woman to decide. Inform her that the current technology of the vaccines has not been shown to be detrimental to the fetus, and there is no report of a pregnancy suffering because of coronavirus vaccine. The On the other side of the Atlantic, the UK government has said that you should wait if you are pregnant before receiving the vaccine. So you have two quite diametrically opposite kind of guidances. In India, there is no guidance as of now, but my feeling is that when the guidance comes out, it will be that the patient should be allowed to choose. So to answer the question, should we give pregnant women coronavirus vaccine? I think the answer is going to be, unless they are at very high risk for acquiring a coronavirus infection, this vaccine, as of now, should probably be avoided in pregnant women. So, where are we now and how to move ahead? We know that maternal immunization is important. We know that TD, Tdap, and influenza vaccine should be used in pregnancy. We await more data on whether the coronavirus vaccine should be used in pregnancy or not. At the end of the day, and